Hello and welcome to this episode of sMater, a podcast by clinicians for clinicians, brought to you by Mater, an Australian leader in healthcare for more than a century. My name's Gillian Whiting and I'm your host, coming to you from Meanjin, the land on which this podcast is being recorded.
And I'm Dr. Maria Bolton, GP specialist and former president of AMA Queensland.
Today we're joined by Dr. Rebecca Farley, Clinical Director, Senior Medical Officer and GP with Mater Refugee and Multicultural Health in Brisbane.
We are Mater.
We are Mater.
We are Mater.
This is sMater.
Rebecca, welcome to sMater.
Thank you for having me. It's a pleasure to be here.
Rebecca, we acknowledge that this is a very big and complex issue, so I think it's important to start by setting the scene. What does refugee health embody?
I think it's a great question. I've thought about this a lot over time, and I think I've been working in this space for about 15, 20 years now, and I think it's become more and more nuanced over time. I think at the end of the day, what it really embodies actually is something that we're trying to achieve across healthcare more broadly. It's about really being able to create those safe, culturally responsive, trauma-informed, healthcare environments, equitable healthcare environments for all of our patients, so that we can then really recognise and respond to the needs of individuals within those environments. So I think to think about refugee healthcare specifically, we're talking about people who have had a forced migration journey of some kind. And I think for all patients, it's important for us to understand the journey. But in refugee healthcare, I guess there's the commonalities that we see in forced migration. But then each individual still has a really unique story. So I guess to speak to those commonalities, we're caring for people who have had to flee their homes. They've often experienced conflict, trauma, sometimes torture. They've been separated from their families, their loved ones, dislocated from their communities, their culture, their homes. So I think it's recognising those commonalities and responding to all of those things that we see, the things that people might have been exposed to.
It's a personal issue for you, isn't it, Maria?
Yes, I was born overseas, and I came to Australia under a humanitarian visa when I was 13, and certainly I grew up in El Salvador, and El Salvador is so different to Australia. And as a teenager, it was quite a journey. Different health system, different education system. I'd never seen a train, for example. I'd never seen a building taller than 18 stories. Huge, and it has ramifications, and navigating the health system here too, because over there it's quite different. Was a huge learning experience, and certainly my heart goes out to any teenager who's in that position, and their parents, of course. But I was wondering, not everyone discloses that they may be a refugee. How do you identify those people who may not disclose that they're a refugee, so that you can provide the appropriate healthcare for them?
Yeah. And thank you, Maria. I think, the story you just shared in some ways really speaks to that in many ways. Where people don't necessarily, people come from along different pathways. People don't necessarily come through our humanitarian program with a certain visa. We'll see people who have travelled to Australia sometimes on spousal visas, orphans. We see sometimes people who have come on student visas or tourist visas and then applied for protection here in Australia. So it's not easy. And I think I often speak to colleagues who say, refugee health, that's not really a big part of my practice at all. I don't know that I'm seeing anybody who's got a refugee journey. And when you start to speak to them, actually, they really, really do, and it's actually a big part of their practice. So I guess I would say really it's more broadly thinking about how does the impact of forced migration impact your patient population more broadly. I think the other really important thing to think about is that it's not just about the initial resettlement period. So sometimes people will or may not want to, define themselves by this experience. I think we're all like that. We don't want to be necessarily defined forever by an experience, but the refugee experience makes up part of someone's story. So that can impact people both, right throughout their lives. It can impact, across generations. So we need to be thinking, really broadly about how forced migration might be impacting our patients, whether or not they might be a second generation, that are still being impacted by some of the factors that we're talking to.
Why is it really important in your mind to identify whether someone is a refugee or an asylum seeker?
When I think about people seeking asylum in Australia, I think about really people who are in that process of applying for protection here in Australia. They're simply still in that process. So the majority of people will be found to have a well-founded fear and will ultimately be given protection here in Australia. But the fact that process of applying for protection can be incredibly protracted, and so what that means in terms of people's, we know the impacts on mental health of that prolonged, application process. So that has to shape our care. We also know that people seeking asylum, and often people are seeking asylum for over a decade, it can be a really, really prolonged journey. People may have been in detention. And in that time, in our community, if you have a protection visa, you can access Centrelink, you can access English classes, your kids can go to school, all of those sorts of things. If you're seeking asylum, if you're seeking protection, all of a sudden, all of those things kind of just go away. So we have patients, and that's really the patients we're caring for here, that I'm caring for here at the Mater, are patients that have unstable access to Medicare. So often people can't access kind of basic healthcare. They may not be able to access, or they can't access Centrelink, may not have work rights, are really limited in terms of financial resources, access to food and housing, can't access NDIS. So being able to understand that and what that means in terms of the patient's needs and what we can offer is really important. And I guess I would just say as well, I think sometimes people ask me about what I do, and they're like, oh, that's really interesting. I didn't know that we had that number of people seeking protection living in Brisbane. So the latest data, and again, this will be an underestimate, says that we've got about 900 people seeking protection in Queensland, and largely living in Brisbane, sort of Goodna, Gatton, Ipswich, Toowoomba, and we're seeing all of those patients here at the Mater. So I think just there can be a group of people that are really sort of not seen in our community and really vulnerable.
Speaking with you and doing this podcast really opens up our minds when it comes to this complex area. But I was just wondering, and it is something that gets touched in our GP training briefly for such a complex area. I was just wondering, are you aware of perhaps any funding that GPs and our teams can access to upskill in this area?
Yeah, it would be wonderful. At times there have been little pockets of funding through PHNs and those sorts of things to do quality improvement activities. The primary healthcare networks have a multicultural health framework, and so we're really working on implementing that at the moment. So that's been wonderful. But I think, but no, I guess is the very simple answer at the moment. But at the same time, another role that I have is as chair of the Migrant, Refugee and Asylum Seeker Health Specific Interest Group with the College of GPs. So, certainly we do a lot of work around developing resources, guidelines, professional development activities for GPs, and I work with a lot of nurses who do the same through the Refugee Nurses of Australia. So I think knowing that those resources are available, that they can make up part of your professional development as a health professional, is important as well and is valuable as well.
Australia has a long-standing tradition of humanitarian resettlement, having provided safety to nearly 1 million individuals since World War II. In the 2023-2024 period, the Australian Red Cross reported that Australia granted 20,000 refugee and humanitarian visas, with the majority of recipients hailing from Iraq, Myanmar, Afghanistan and Syria.
So for a newly arrived refugee or asylum seeker walks through the door, what makes up the essential components of that initial health assessment?
So effectively, I guess there's a lot of evidence to support, really, we talk about sort of comprehensive patient-centred catch-up care in the early resettlement period. And so essentially that health assessment really comes down to a really comprehensive history, physical examination. There's investigations that we recommend, screening guidelines to inform the kind of things that we should be thinking about. and then developing a management plan. And that really considers obviously all of the things that the patient may have been concerned about or presented with, anything that may have emerged from kind of recommended screening should the patient have wanted to take that up, and then things like catch-up immunisations, those sorts of things as well. So yeah, I think it really guides that preventative health care that we would offer somebody who might have experienced a refugee journey. And I think, to build on what I was saying before, I mean, that health assessment it's really a clinical guideline. There are Medicare rebates, so that fits under the health assessment item numbers, that there are Medicare rebates for if somebody's accessing that in the first 12 months after arrival and have Medicare. But I would say, so many of my patients don't have Medicare. It doesn't mean that I don't offer them the same care that's recommended in those guidelines. And I might be seeing someone 7-10 years down the track. And if it's the first time that I'm seeing them, I will still go back to those guidelines and make sure all of those elements have kind of been touched on or offered, I think is the really big thing. And it's amazing how often that early resettlement period there's so much going on. There are so many competing priorities. It's amazing how much something might have been missed.
That Medicare card is really key, isn't it? Particularly as a GP when you're trying to work out perhaps what bloods to order, and understanding how much they cost and whether or not you do need them. But I was just wondering, are there any particular conditions that affect specific refugee groups, and how can we as a GP practice team address them in a culturally sensitive way?
Yes, absolutely. As is true for all of us, depending on the patient population that we're a part of, there will be specific things that are more prevalent for women of a certain age, or and we need to be thinking about those things. So we do. Again, I've spoken about that journey. So because of reasons of perhaps physical injuries during fleeing a conflict. The mental health implications of a prolonged sort of journey and the trauma that might be involved in that. Because of the geographic locations people may have moved through, we'll see exposure to different infectious diseases. We certainly see nutritional deficiencies. People have experienced food insecurity, and I guess also we see a lot of delayed presentations of whether it be malignancies or chronic disease because people haven't been able to access preventative healthcare. So absolutely, I think the really common things we talk to really probably are, we talk to infectious diseases. We see higher rates of strongyloides, schistosomiasis, hepatitis, and those things are dependent really on the journeys again. We do see higher rates of mental health concerns and PTSD in particular. We do see nutritional deficiencies, iron deficiency, vitamin D deficiency, B12 deficiency, and again you'll see all of these things kind of really outlined in those recommendations around that health assessment and catch-up care. And more physical injuries, and as I said, delayed presentations of a lot of other conditions. And I guess what I would say though is really important is that patients will still come, as we all do, with their concerns. And the most important thing is to be able to respond to those concerns in that initial phase, rather than being like, oh, I'm thinking about all these other things. And I think the other, when you talk to responding in a way that's culturally responsive, I mean, you can't have these conversations without working with an interpreter. If the patient doesn't speak English, you need to access an interpreter and work with them. I think often we can kind of fall into the trap of sort of saying, oh, this is what we have to offer, and just almost assuming that this is the way it will be done. So being able to recognise the importance of really working with your patient and being able to explain why we offer these different things. And like preventive healthcare it's an interesting concept, and it's not universally available to people. So being able to explore that with people. And I think the other thing that I'm really careful to do is, as much as possible, kind of normalise this. So I'll talk about the fact that, yes, we see a lot of strongyloides. It's really prevalent in Papua New Guinea, actually really prevalent in northern parts of Australia too. So this is something that we think about for patients who have lived in Australia as well. We're offering these catch-up immunisations. These are the same immunisations that my child had. So being able to normalise that as much as possible and being really careful. Sometimes I think it can feel quite othering to say, your population experiences this.
Yeah, expand on why it's important to work with a trained interpreter rather than perhaps using a family member or a partner to interpret it?
Absolutely. I mean, I think there's some beautiful research, and I might share this as well, from a GP in Canberra, Christine Phillips, looking at some of the negative outcomes when you don't work with a professionally trained interpreter. It's an incredibly difficult job, and I think I've become more and more aware of that over time, and the interpreters that we work with are incredibly skilled. It's I guess the expertise involved in being able to take sometimes these concepts, sometimes something that we might explain in a few words will take a few minutes for an interpreter to be able to explain and to be able to share that message. And I think when you're working really collaboratively as two professionals, you can really develop that shared understanding and make sure that the communication is clear. So there's a kind of professional expertise and skill that we're seeing when we're working with interpreters. I think the other issue is obviously when you're working with family or friends. One of the I remember really clearly one of the examples in that research that I was speaking to. Somebody, a parent who is presenting with and needs to talk about their experience of trauma, or perhaps has a sensitive issue that they want to talk about, pregnancy or a women's health issue, and then we use their child to interpret for them. No parent is going to say what they need to say when it's their child who has been asked to interpret, and the harm that we can cause in doing that is profound. And so we really need to be incredibly careful with obviously with children, but friends and family as well just don't necessarily have the skill, the expertise to be able to interpret in the way that we need, and also we'll sometimes try and protect their friends and their family as well. So there's other factors at play.
Rebecca, you spoke about there is so much going on for people when they arrive. It is such a busy time, and also mentioned PTSD and mental health issues. Those migration and social issues for seeing people like that, refugee patients, how can they be addressed, and any other advice you can give around that?
I mean, I think the conversation around those mental health implications, I think, is big, and we can certainly talk about that a little bit more. I think in terms of some of the other social factors that are impacting on our patients, I think again we're pretty used as health professionals to thinking about what's going on outside our consultation rooms. And for patients who have recently arrived as as refugees, there's so much going on, and so I think those conflicting priorities and not even knowing really what you should be doing, what's most important. We're recommending that people, get to TAFE and go to English classes. They're trying to enrol their children in school, trying to find housing. Often people have really unstable housing. So all of those factors are really significant, and that's all on the background of often having friends, family, loved ones who are overseas and are unsafe. So if we're trying to, pursue our refugee health assessment and we're offering, cervical screening, often that can be really out of touch with the reality of what somebody is living through. So I think being really mindful of those things and adapting your care accordingly, and just being responsive to the needs of the patient and what's a priority for the patient at the time, and just recognising that there are so many services available to support you in that. So, often we'll be working really closely with settlement services. We work quite closely with TAFEs and to try and, make sure that people are able to get to where they need to be. Absolutely, schools, having children in school is so important. So really working closely with those other organisations, I think is probably the main thing. Yeah.
Vaccination is a priority in refugee health, and often you'll get people who come from overseas who may not have medical records or vaccination records, or if they do, they may be in a different language. How do you support this community when it comes to increasing and supporting their vaccinations?
I think probably one of the first things to actually remind ourselves of when we can think about that is actually there's lots of us as health professionals that don't recognise that everybody who's come to Australia as refugee or seeking asylum is eligible for government-funded catch-up vaccination. So I think that's the first thing. And I think then also talking to the fact that the things that we've already spoken to, actually recognising when somebody might be eligible. So many people that we're just actually not offering catch-up vaccinations to. I think the second thing, again, is then to be mindful of just how, again, people have not always had positive experiences with healthcare overseas. We're not, I think we know we're doing our best. We want to do good. We should be trusted, but that's not always been the case for people through their journey. So, being able to really sensitively talk to patients about why we offer these vaccines, what they are, what are we offering with these vaccinations, what are some of the adverse effects that they need to be mindful of, all of those things that we do for everybody, but doing it in that really culturally responsive way, really watching for those signs in the individual that they're not understanding, that they're disagreeing, that this doesn't make sense. Making sure that you've used that you've engaged with a professional interpreter is really important. So all of those things, I guess, are part of it. I think, as you said, we don't always have records of what may have been offered overseas. So again, there's really beautiful guidelines around this. So our nursing team here at the sMater has some beautiful resources on the Refugee Health Network Queensland website. If we don't have records, we do recommend offering a full catch-up schedule. Basically, that will be that, basically so that you've been offered the same immunisations that someone of your age would have been offered in Australia. Obviously, that is informed by your medical history. So if you do have records, that's wonderful. If we can get those records translated, that's wonderful, and that will inform what we offer. But we wouldn't routinely be doing a whole bunch of serology.
What signs of trauma should our team be aware of, and how can we help people through it through trauma-informed care?
To the context of refugee healthcare, I guess more specifically, we're really aware through that migration journey that almost without exception, our patients have experienced trauma, and so just being aware of that is actually the first step, of being sensitive to that is the first step. We don't recommend necessarily that you would ask someone in detail about their trauma experience, and I think really recognising the potential to do harm if you don't have the time, the space, the expertise, the skill to be doing that is important. But at the same time, not being aware or sensitive to the potential impacts is equally potentially harming. So, I think often in that early resettlement period, we're just sensitive to the fact that this might be impacting people's concentration, their memory. You'll see those little things in consults. You'll see people getting, more and more kind of agitated or anxious or perhaps withdrawn, kind of just going somewhere else. And I think being really sensitive to all of those things in that early resettlement period is important and kind of enough. And then over time, I think you start to hear more and more of, my experiences around somatisation, headaches, chest pain, some of the regional pain syndromes that we see, which are really complex to manage. And I think, again, just to know that there are services available to support patients. We in Queensland, again, very lucky to have the Queensland Program of Assistance for Survivors of Torture and Trauma, which offers specialised counselling. But again, where patients, again, how you discuss that and whether that's something that people want to access is a really big question. It is a lot, and I think sometimes as clinicians we think we somehow need to jump in and help and fix things and find solutions, but actually that trust and rapport that we build just by being there in those early consultations, I think is really important. And I guess I'm saying that because I think it can be really difficult for clinicians I think we get fearful that we need to do more, that we need to know more, that we need to do something. And so if you can create a safe space, that's a huge thing. And then as time goes on, when you've been sensitive to all that along the way, then you get to the stage where someone says, I experience these symptoms and they seem to be related to these thoughts or and at the same time these experiences, and you start to be able to have those really meaningful conversations where you can start to really offer people the care that they need and the treatment that they need.
If we talk more about the environment itself and the consulting rooms, And how do you make that a safe and trusted place for these particular patients?
Yeah, I mean, I think there's I think all of those things that you hear are so true. I mean, so thinking about, the artwork that you have on your walls and the images that you have on your walls, and making sure that you don't have a lot of information in a language that people won't necessarily understand. All of those things are important. Having a calm space is important. I can think of recently a woman, she was from Papua New Guinea, looked at some of the brochures that we had on the wall. We have guides in different languages about the healthcare system, and she sort of said to me, that person's wearing the traditional dress that we wear. It's just those things are lovely, and they're really important. But I actually think beyond that, actually what's most important is the way that everybody in your practice responds when someone walks into the clinic. It's the warmth and the welcome that people feel when you come into a clinic.
Are there any other particular resources that you wanted to mention, or that you think it'd be helpful for the healthcare teams more broadly?
Yeah, oh gosh, so many resources. I think probably the really big ones to know about as clinicians is certainly that Refugee Health Guide. So that was developed in collaboration between the Australasian Society of Infectious Diseases and the Refugee Health Network of Australia, and it's a really comprehensive guide, not just to the management of infectious conditions, but broadly to refugee healthcare. It speaks beautifully to some of the mental health factors that we've discussed today. But in Queensland, we're really lucky. We have the Refugee Health Network of Queensland, who also have a beautiful website, and you'll just find a wealth of resources there. So there are resources around how do you create, absolutely, a guide to how do you make your practice welcoming to somebody from a refugee background. How do you access interpreters? What resources are available? Lots of patient information in language, education, that sort of thing. If you're really interested, that network has an e-news, so you can sign up for the e-news. And we run education and at the quarterly, basically, we run education sessions. So they're all available online as well, and we'd love to see people in person as well.
Smater Refugee and Multicultural Health is a national leader in delivering care for multicultural communities. In the 2023-2024 financial year, it provided culturally appropriate care to 1,768 patients, many with complex healthcare needs. The long-serving Smater Refugee Complex Care Clinic, which is the only Queensland Health Funded GP medical service for people without Medicare seeking asylum, saw 470 of those patients across GP, psychiatric and paediatric services.
What services are available at the Smater, and who can access them, and how do we refer to them?
So our team in the Smater Multicultural and Refugee Health Department, we have several clinical services. So we have the Smater Refugee Complex Care Clinic, which is a service specifically for people seeking protection who may not have access to Medicare. So we provide a general practice service for those patients. We could also have the Multicultural Health Coordination Program, which is a service delivered by nurses and social workers who basically their role is to help coordinate care for people from a multicultural background. So it's a broader service and liaise really closely with GPs in the community and then the hospital system. We also have the Smater Integrated Refugee Health Service, again a nurse-led service that is really there to support patients in that early resettlement period. So that's caring for patients who've come through the humanitarian program, and the nursing team will really look at to providing an initial nursing assessment and then work collaboratively with GPs in the community to provide that medical component of that assessment as well. We've also got a paediatrician and a psychiatrist that work in the service one day a week. And so again, basically you can access our website and there's referral forms for all of those different services. And I think, again, more broadly, there are, we do in maternity, we've got a refugee health specific service. Again, we work really closely with infectious diseases, cardiology. I think a lot of the other specialties within the Smater Hospital who we would refer to as we would for any patient.
What services are available for asylum seekers and refugees who live outside of Brisbane?
I think that's a really challenging question. So as I said, we do, and this is not ideal, we're really the only funded service to see people seeking asylum who might not have access to Medicare. So we here in southeast Brisbane will see patients from Toowoomba, from Ipswich, from Gatton, from Goodna, which is obviously not ideal in terms of their transport needs. And we do what we can to make sure that is as patient-centred as possible, and we use telehealth where we can. But that is a very real gap, I think, in the services that are available in Queensland, and it's only been relatively recently that the service here has been funded to see people without Medicare. So it is a significant issue. I think I would say as well, the MARTA auspices the Refugee Health Network of Queensland, and part of that team is a Refugee Health Fellow, so a GP again with a wealth of expertise and experience in this space, who is there to support clinicians across the state. So we certainly see GPs around the state offering pro bono care. In terms of accessing hospitals and any hospital-based service, basically Queensland Health since 2017 has had a health directive that says that people who are seeking asylum without Medicare can access services at no cost to themselves. So people absolutely can still access care in our Queensland Health services. And again, we also have some of the urgent care clinics have also made themselves available to see patients without Medicare. So there are options, but they're certainly not. They're certainly not ideal when you can't access. I think general practice is such a key and integral, component of our healthcare system. If you can't access that, that's a real challenge. And I think a real challenge is also sometimes hospitals and health services around the state aren't necessarily aware of the Queensland Health Directive. So we're so used to asking for a Medicare card, and when someone says that they don't have one, immediately saying, well, you can't access the service. So really ensuring that people know that patients seeking asylum are eligible for care is really important.
So there seems to be a lot of need to expand these services, essentially. And I was just wondering what the role of advocacy is in ensuring that this happens.
Yeah. I to be honest, I think the space that I'm working in with people who haven't got access to Medicare and are seeking asylum, that's because there was a gap. There was a gap here in Brisbane as well. We knew that there were patients who just simply couldn't access care. And so there's been a lot of advocacy for a long time, I think, to address those gaps. I speak to 2017 and the introduction of that Queensland Health Directive, meaning that people could access care in hospitals. Before that, we absolutely saw patients presenting with ischemic heart disease and being turned away. And there were some very prominent cases there, or being seen and then chased to pay bills that they simply couldn't pay, and then the mental health impacts of that. So in 2017 in Queensland, the first policy and action plan for refugee health was launched, and I having worked before and after that, I think it's been very clear to me how important that advocacy was, and having that clarity in terms of policy and priorities in Queensland Health has been in terms of actually, shaping what can be offered, what is resourced, and bringing together what is sometimes really disparate services in the past. So I think that advocacy has been incredibly important, and it's something, I think, Maria, in your earlier question, we're not done. There are so many people settled in regional parts of Australia who still haven't got adequate access to care. And so it's an ongoing journey.
What does the future hold, do you think, in this area of healthcare, Rebecca?
I know what I would love it to.
Yeah, we can start with that. What would you love to happen? What do you think is important to happen?
Yeah, I think as a clinician kind of, working day to day, the first thing that I would hope is that, that we all develop the skills and the knowledge and the experience to be able to deliver that culturally responsive, trauma-informed care to all of our patients, and to be able to recognise those that might have had a forced migration journey or might be being impacted by a forced migration journey. So be able to do that well and be able to do that across all of our different healthcare services. But I think, I've been really fortunate in my career to be able to work with people working at that policy and advocacy kind of space. And I think, as I've said, we've seen incredible changes in Queensland that have absolutely shaped the care that we're able to offer. And I think, recently we've really been able to see that in response to the pandemic, in response to emerging humanitarian crises overseas. We were able to really quickly mobilise access to care for people coming from Ukraine. At the moment, we can access care for people coming from Gaza. We can do all of those things. But before we had those systems in place, we simply couldn't. And so I think really one of the biggest challenges for the whole sector now is that we still see a lack of coordinated, sort of integrated policy at a federal level, if that makes sense, and that's why we're seeing these real gaps in general practice. So I think a real focus for us as a sector is really about how do we start to ensure that at a federal level, health is involved in those conversations so that we can meet the needs of the communities that we are welcoming into our country.
As I said at the beginning, this is a very big and very complex issue.
That may have been too big and complex.
And congratulations on the work that you do, Rebecca. Thank you so much for joining us today. But before we go, we just wanted to introduce you to a little segment that we call the Checkup. So we have a deck of 5 cards with 5 very random questions aimed at giving us an insight into you. So it's meant to be a fast 5. Are you ready?
Sure. Okay.
Rebecca, if you could impart one piece of knowledge on a medical student, what would it be?
Probably actually a question around culturally responsive care, actually, probably. People often ask me about what does that mean and how do you develop your skills in that space, and I think probably it's about, I would love those medical students to be mindful of their journey and what's shaped them and how they've kind of lived and moved and walked through the world, and where they sometimes might not be seeing the bias or the prejudice that they might hold. And I think when you can really start to lean into those conversations with your patients, understand their perspective, understand that it may be very different to yours, but there's so much to learn from that, and really I think that has really shaped my care over years, and it's the thing that actually brings me the most joy, being able to bridge those cultural differences and find a shared understanding.
Who do you admire?
I guess I've been thinking about this conversation, so I might just say that I really admire. I have the most incredible team, all working in really different professional roles. We're from different cultural backgrounds. We're a really diverse team, and when you think about this conversation, just to think about how everybody's been able to come together to make great changes and deliver really good care, it's really lovely.
What was your first concert?
First concert? Oh my gosh. I love a festival. So I'm sure I was at some form of music festival. There would have been camping involved and probably some folk sort of, maybe Missy Higgins with some bare feet, I don't know, something like that.
And if you weren't doing this, what would you be doing?
I think working with people from different backgrounds to my own and learning how to do that well, and being able to support people at a time when they are really quite vulnerable in our community. It's just been an absolute joy. So I haven't thought hard about what else I might be doing. I'd love to be an artist or something, but I feel like I haven't put the work in there.
And final question, if a genie could grant you one wish, what would it be?
Working towards some sustainable solutions to some of the conflicts that we're seeing, and being able to, as a society, certainly at least here in Australia, we are incredibly privileged, and we're in really fortunate positions to be able to really welcome and appropriately support the people arriving here into our country, and to be able to recognise just how much we all have to learn from each other, and how much richer that makes our society. I think I'd love that. I feel like I get to experience that in my work day to day. It's a pretty magnificent thing, actually.
Indeed it is. Thank you so much for joining us and sharing your experience with us today on sMater.
My pleasure. Thank you both.
For our listeners at home or in the car or having a well-deserved break between patients, thanks for tuning in.
See you next time on sMater.